First of all, I would like to thank Dr. Magdi, Professor Magdi, for his invitation and for this elegant program and conference. Our next speaker is Professor Bernard Canaud. His presentation is about big data management in end-stage renal disease.
Thank you. Good afternoon. Thank you very much for the kind invitation and kind introduction. I just want to thank the steering committee, particularly my colleague, Professor Magdi Shakawi, and also Isha Sayed for this kind invitation. So within a few 20 minutes or maybe less, I will try to convince you that the big data analysis, big data management, which is a magic word, is certainly a new way to perform what I call future medicine. And then to convince you that maybe taking advantage of population base, we can move on a personalized medicine. This is my conflict of interest, just to confirm. And this is the outlook. So I will show you what is the big data, the challenges of the healthcare system, and we are faced, even western part of Europe. Modern technology, how to use this type of information, communication, regulatory aspect, that would be the next step. But still, it's a very fascinating topic. So, big data management, what we means within big data is a part of what we can call population-based and personalize it, or even, depending where you are. But the idea is, of course, to use this type of example to apply to chronic kidney disease management to see what we can learn, or what we learned over the few last years using this type of, I would say, analytics, because it's not only the big data, but it's the analytics that you can perform with this big data. And before starting, I would say, what are the challenges today of the healthcare system? And certainly you are facing the same in Asia. Clearly, when you talk about the CKD care, we are at a crossroad. We have patient needs, we have to create or to sustain healthcare model to make sure that we are not collapsing. So economic sustainability, societal value. So that means it's a complex system where we have to think about. And if you look all together, and I put this slide, if you look the healthcare system, you can break with a different aspect. CKD epidemic, we learn, an economic burden. Fragmented care, we listened this morning, kidney doctors shortage, certainly a new, I would say, difficulty. Healthcare, I would say, giver shortage, variation in care quality, patient demographic. So if we put all together the difficulty to make sure that the CKD care will sustain. I'll just give you some examples. This is coming from the last Lancet analysis, showing that within 2030, maybe this would be about 6 million, but certainly much more if you just look in India and China, but this is the estimate for the next, I would say, 10 or 15 years. So 6 million in dialysis. Again, this morning it was, I would say, mentioned that certainly CKD care management is completely fragmented. So this is a lot of, I would say, opportunity using a digital system to make sort of, I would say, make this fragmentation reduce and to have on one side all this information. The third aspect is, of course, the cost. And if you look at the cost of end-stage kidney disease, depending on the country, I don't want to go into detail, but it is a tremendous cost. And of course, more you go to the US or Europe, you see the tremendous cost. And you have to multiply by 10,000 to get, I would say, the cost annually. So how it could be sustainable over the time? This is from the US. National Resident Matching Program, showing that the need is increasing and the numbers of applications is reducing. So that means there is a lot of question about that. And also from the docs, just to show the mortality is completely different. Even if you compare, I don't want to compare the different countries, but the same, I would say, GDP by the country, and you see the mortality rate, which is completely different according to the country. So that means practices certainly affect the mortality of the patient. And then also, Another point, I was interested when I prepared the talk. If you look at the medical knowledge, now it doubles every 2 months. So look, from the 1879 till 49, and then now we are doubling the knowledge every 30 days. So how can a physician make sure that they can learn everything every 2 months? It's almost impossible. So that means now, healthcare system pressure, we get a lot of, we say, rise in healthcare costs, high demographic pressure, we have some improve the better outcome, find some cost-effective solution. This is a question. And of course, what could be on the other side to find some solution? Improve the care or the patient experience, improve the population and healthcare outcome to reduce the cost, reduce care variation. So there are a lot of opportunity. And just to close this chapter, this is my personal vision. When you think about the CKD patient outcome, it's not just based on one product. It's a complex equation. You need to understand what is the patient profile in terms of risk quantification, what is the medical device doing, what is the caregiver skills, what is the patient management. So it's a complex way to understand. And certainly this is perfectly summarized from this New England Catalyst. I like this type of article where they put value-based, what is the patient-centered care, what is the population accountable care for in a national health service, so patient engagement. I will show you this element. This is certainly where we have to think about, and certainly the digital system will put a lot of opportunity to improve the, I would say, solution. And not finished, because if you look on the healthcare model, we start with, I would say, fee for services, and then you see that at the end, we are on a care value base, and that's certainly capitated arrangement, so share savings. So at the end, we change completely the model to make sure at the end, we can improve the outcome of the patient and to reduce the cost. This is the main message. And it's almost impossible to make this challenge if you don't use a digital or, I would say, big data management. This is coming from the US, from, I would say, the Porter concept, value-based system, just to show that we are not just focusing on the outcome, meaning on the result of the patient, but we have to combine the outcome of the patient and the cost. So meaning that we have to combine what you put in the basket and what you gain for the life of your patient. So just put that in perspective. Now we move on the technological aspect. Modern technology, information, communication. And this is certainly a fantastic opportunity. So you know that on the left side, this is a population base, and of course, as soon as you are using your iPhone or moving on Amazon or what you want, or Google, so many information are collected. And this is a fantastic opportunity to understand and to transfer this knowledge in, I would say, personalized medicine. So the point is to understand how to use this, all the information that we collected in medicine and the CKD management, and to make sure at the end we can have a very precise, personalized medicine. I don't talk about genetics. It's a completely different story. But you can make the parallelism if you just replace, I would say, the genetic by all this information coming from the phenotype and, I would say, practices and lifestyle of the patient, and a lot of information coming from the patient. You can use this information to make something better for the patient. Of course, you need to get tools. And this is the point. This is artificial intelligence and all this stuff which is behind, I would say, neuronal networks, machine learning and all this stuff. But the idea is to collect this information and to transform this information via the artificial intelligence, to make it very simple, to define a law, and then to make sure at the end you can have a sort of predictor or certainly a support for the patient. You can support the decision of the physician, you can support decision for all the, I would say, care provider. I selected 4 main pillars. One is a predictive medicine, one is a precise medicine, disease management, and value-based healthcare system. So now, if you look at the predictive, of course, the idea is to support the decision making, to permit risk stratification, to optimize the patient trajectory, and to reduce treatment uncertainty. This is just summary. You can find a little bit more, but the idea I will show you. Artificial intelligence in hemodialysis, and we know that in dialysis we are generating so many data every day, every session. So if you collect this information, and of course if you have the capacity to transfer all this data to a sort of system, when you can apply some modeling, artificial intelligence and so on, then you can transform this information do a personalized way for the patient. I will show you an example. One, just to understand, of course, for the population, you need to get observation for the population, you need to get sort of artificial neuronal networks, you need to have strong analytic modeling, and you need to have a machine learning, and just make sure that you can define some laws and then to apply for a specific patient. Sure, I will show you one aspect. One is the anemia. And of course, you know that anemia is not so easy to handle in a patient. But at the end, if you look what you are doing every day, this is your brain as a nephrologist. You get so many information about the patient profile, vascular access, iron, and everything. I don't want to go into detail, but maybe you have 20 inputs. And then, based on your knowledge and not artificial, but natural intelligence, you define what is ESA dosage and iron prescription. So, multiple input, limited output. Now, if you look on a different aspect and you put artificial intelligence in the model, and this is some example from the papers, Kidney International, I don't want to go into detail on the aspect. This is one typical patient. Before that, a patient is handled by regular, natural way of the physician, and you see the fluctuation of the hemoglobin, you see the change of ESA dosage, and as soon as the patient is entering in the anemia control module with the artificial intelligence, you see what's happened with the hemoglobin. You can just almost skip all this fluctuation of the hemoglobin. And what you see also, you reduce tremendously the amount of erythropoietin given to the patient. So, different study, I don't want to go in detail, but in summary, I would say, if you look, patients who are in target, and the target for this study was 10 to 12 grams, very limited and narrow, you can increase by almost 37% of patients in target, just based on, artificial intelligence, doing much better than, natural intelligence. You gain almost 25% of the patient in target. Not only in target, but you reduce the change or the target of the hemoglobin fluctuation. So there is no more fluctuation of the hemoglobin, and maybe the variability of the hemoglobin could be part of the outcome, poor outcome of the patient. But not only, you reduce the consumption of ESA. Look, 50% decrease of the consumption of ESA. So, same target, same efficiency, reducing the cost. Not only on the anemia, but there is a different aspect. This is coming now for the fluid management and hemodynamic management. I'll just give you two aspects. The idea is to identify what is the ultrafiltration rate, treatment time, to predict or to anticipate hypotensive episode in a patient. And then, based on this algorithm, you can find some logic or some algorithm for the patient to identify what is we need artificial intelligence. It's coming back. So good point. So you can anticipate what will be the optimal ultrafiltration rate for a defined patient, depending on the time, depending on the, condition of the patient. Next is, of course, precise medicine. The idea is to customize the therapy, because one size does not fit all. This is clear. So also to make sure that we get a patient engagement and we want to understand what is relevant. So I'll just show some examples. In terms of predicting modeling, if you want to understand how many patients will move from stage 3, 4 to end-stage kidney disease, you can implement, this is a study, Tangri, I don't want to go into detail, but factors which are used are very simple. And then based on this element, you can anticipate what will be the patient moving to the end-stage kidney disease. And I don't want to go into detail, but depending on the model that you put, you see that at the end, the prediction is very close. So that means if you implement this type of model in the artificial intelligence, you will anticipate how many patients you will get at the end of the year on the end-stage kidney disease. So now, of course, not all the model works perfectly, and this is a nice review from Amstec, clinical epidemiology, showing that if you use flood, Holmes, Wagner, and you compare the predicted probability versus the observed, you see this is almost perfect, this is fine, this is completely wrong, this is completely wrong. So you have to identify what is the best modeling, and certainly this is a nice way to improve the, I would say, accuracy of the model over the time. But still, at the end, you know, if you compare the different, I would say, modeling, and you validate with your original data cohort and then with external cohort, you see that at the end you can have a very strong prediction of what are the patients moving to this next stage. Disease management, this is another story. This is coming from Fresenius, and you know that Fresenius in Europe get, I would say, tremendous database which is called Euclid. That means every day they are collecting for 70,000 patients all this information coming from the patient, from the machine, from the pharmaceutical company, from the pharmacy, from the labs. And this is just sent and make analysis and making analysis every month. This is provided to the physician in charge of the patient. So that means you get a dashboard where you see here, for example, I would say some centers which the target, nutritional aspect, fluid management, I don't want to go into detail, but you can identify within the centers how percentage of the patient are in target, and certainly in the center, I did not show you how many physicians are in target for what they are doing to the patient. And if you apply that, and this is just a few examples, I selected Portugal, Romania, but it's the same everywhere. If you see just for the ESA consumption, look what happened. Different country, this is following the guidelines, I would say European guideline, and then following artificial intelligence or ACM. You see that you can reduce tremendously the consumption of ESA. Look, moving from 23,000 a month to virtually 10,000 or 13,000. So you can reduce tremendously the consumption of ESA, keeping the patient with the same hemoglobin value. Not only this element, but of course, you can reduce morbidity. This is hospitalization. Look, you can reduce numbers of days of hospitalization. You can reduce also vascular access management. You see, this is a percentage of patients having, I would say, some dysfunctioning of the vascular access needing to be hospitalized. So you can reduce any type of vascular dysfunction or even infection. But also you can reduce the mortality. So if you compare, I would say, 2010 versus 2014, you can reduce mortality. So there is, without, I would say, doubt, a tremendous opportunity to improve the outcome of the patient. So time of the personalized medicine is certainly coming. And of course, in dialysis, we are not escaping. If you look in, I would say, drug, pharmaceutical, I don't want to go into detail, antidepressant, asthma drugs. Of course, we know that we have to move to a personalized drug therapy now. We cannot apply, I would say, all the drugs to the same population. We know that sometimes the disease response, side effects are a little bit different. So could be, I would say, an opportunity. But then if you apply the same concept to patient on dialysis, of course, could be renal replacement therapy. Why doing 3 sessions a week, 4 hours, when we know that a different opportunity, maybe we have to change depending on the patient, depending, I would say, profile of the patient, depending on the artificial intelligence, maybe you have to define completely different, I would say, treatment schedule for the patient. And then that would be I would say, functionality of the support of the new tools. I will show you some elements. This is, for example, coming from France. We have a national registry which is collecting for almost 15 years now, and they make analysis and the question, because now, if you look on the geriatric population, the idea is not just to take a patient 75 years old and put on dialysis. The idea is to see what will be the outcome of this patient, and then they develop a concept with a formulation to individualize the care plan of this patient. Could be palliative, could be conservative, could be dialysis, could be transplant, with a strong, I would say, value inside, because you can anticipate what will be the outcome of the patient. I will show you some examples. This is a go also from Flood. I mentioned his name. collecting information from the patient side, collecting information from the lab data, but you see it's not, I would say, so complex element. Cardiovascular history, ESKD, I would say, from body mass index. So you collect all this information and then you can make an outcome prediction. So if you manage this element, you can anticipate what will be the mortality of the patient for the next or for the 2 years. So this is a cumulative point. So at the end, you just make a sum and you put that in the laptop system, making analysis, and then you know exactly what will be the outcome of the patient within 1 year, within 2 years. That it works? Yes, it works. Look, predicted mortality versus observed mortality at 1 year, and the same story for 2 years. So at the end, you can rely on your prediction. I don't want to say you have to follow exactly what the model is saying, but you can be sorry. Thank you. So the modeling, it works. So next step is of course value-based, improving the outcome, reducing the cost. What we can do, and if we look on this pyramid, which is coming from this sentence, of course, this is what physicians or nurses are interested, but what the patient are interested is just on the tip of the pyramid. It's just, I would say, quality of life, and this is based on patient-centric care. Patients need to be engaged, need to get better experience for their treatment, so that means we have to find new elements. I don't want to go on engagement, but this is a nice way to make, I would say, home therapy if you are interested. But now there is a different initiative, and you know the song. If you look what the patient is looking for, is just to be less fatigue, less cardiovascular, less vascular access, but they don't care about the pressure, they don't care about the cardiology. Same story if you look on the eye shot, you see the fatigue and the pain, functional activity. So at the end, now we have to focus on the patient, what they are looking at in terms of activity. And this is coming again from the US, tested in a European, I would say, study that we are performing. Patient-reported outcome measurement, but based on a PROMIS system, which is a self-reported healthcare interactive questionnaire. So that means this is based on a tablet. Data bank is a computerized adapting, so meaning at the end, it's not SF36, which takes half an hour. Could be, I would say, a few questions, focusing on the patient interest and then providing to the nephrologist some information. And the last point is, of course, regulatory. Of course, we are opening a new box. This is black box medicine, legal and ethical, I would say, issue, of course. Do we have to follow the machine? Do we have to follow the recommendation? I don't want to say. The point is to understand where is the degree of certainty or uncertainty. Of course, when I say the patient will die within 2 months, is it true or is it not true? Maybe you have some question, and certainly we have to identify what will be acceptable.